Hello, everyone. My name is Bilal Hussain. I am one of the hosts of today's program. Dear audience, it is my pleasure to introduce Dr. Shumir K. Shaha. Dr. Shaha is the head of microbiology at the Dhaka Shishu Hospital, and he is also professor of Bangladesh Institute of Child Health and the founder and executive director of the Child Health Research Foundation. He is an associate of the Department of International Health of Johns Hopkins University and adjunct scientist of ICTDRB Bangladesh. Dr. Shaha is a member of Pneumococcal Awareness Council of Experts, also a member of WHO's Technical Advisory Group and National Immunization Technical Advisory Group, Bangladesh government. Dr. Shaha earned his BSc and MSc from University of Dhaka in Bangladesh in 1983 in microbiology, and he did his PhD from Institute of Medical Sciences of Banaras Hindu University, India, in 1989. Shaha has published more than 150 papers in peer-reviewed journals. Dr. Shaha is a renowned Bangladeshi clinical diagnostic microbiologist and public health expert, and well known for his research on pediatric infectious diseases. In 2017, Shaha was the first scientist from a developing country to receive the ASM award for his outstanding research in clinical microbiology. Dr. Shaha has received several awards, including the UNESCO Carlos J. Finley Prize in Microbiology. He has been lauded by Bill Gates for his accomplished work involving child mortality in Bangladesh. Sir, the floor is yours. We will give you a reminder 3 minutes before the end of your time.
Thank you. And I am looking at the title, in fact. So it's very, very similar what really Rubaiyat the pace. We didn't talk with each other, but it happened to be the same. So it's a good thing. The only difference I will be that all four talks are very, very same topic. We just wanted to make sure that the people are knowing about the clinical microbiologist of this. But the only difference is all other speakers before, they have something structured. They're working at a place which is structured there. But Bangladesh, I'm from Bangladesh, there is no structured way that you can be a clinical microbiologist, number one. And number two, remember that if you really want to be a clinical microbiologist or medical microbiologist, you have to be a doctor, for sure. And that's really you cannot change because it is not really a rule that government can change. It is an ordinance. An ordinance means it is maybe from the British period, and it will take maybe another decade to change it. Anyways, so that means you need to be a doctor. But before I really talked with Morshed recently, I was not knowing the difference between clinical microbiology and medical microbiology. I was thinking that it is same because the terminology is not there in Bangladesh. So I was thinking that, so you have to be a doctor and there is no other option. But still, sometimes it happened, that exception. And that exception is that possibly happened with me. So I don't know how it happened. What I will say, as there is no other example, the beautifully Rubaiyat was showing about what he does in the lab and everything. I'll be also telling the story, and in between I'll be showing you some of the work that we are doing. Then at least you will be having the confidence that even in Bangladesh, people can do some work if you really want to. So I did my graduation in botany, not even in microbiologist. Then post-graduation, and same with Morshed, in fact. The post-graduation in microbiology in Dhaka University and PhD in the Institute of Medical Sciences in Varanasi. So those are my academic things. But the diagnostic microbiology is possibly one of the most neglected subject, at least by the microbiology graduates. They really do not want to come for the diagnostic laboratory, but they always think, oh, that's not the case. There is no carrier there. So that's one of the important things. And then they will be saying that they only come to these labs when they can see waiting for another job, or maybe they are going abroad and having few months, okay, let's go and do some work there. Otherwise, nobody wants to come. Why? Because everybody want to do research, and their perception is that that you do not have the opportunity to do the research when you are in a diagnostic lab. That's one. And second thing, everybody wants to publish in Nature Science, sorry, Nature Science and Lancet. So otherwise, there is no charm. So that's another thing. So there's all these are big problem. And the options of careers, in fact, publication is great, but at the same time, you can other things also. You can be a policymaker. You can be a policy decision maker for the country, for the region, for the world, or you can do the both research and also this. So I'll be showing you that how that can also happen if you really want to do this. So that was my story. In fact, 1994, when I first joined in Dhaka Shishu, I was sitting in a corridor, in fact, in a broken stool, in a broken table, and a stool, in fact. And that is the place where I was sitting and with some glass petri plates. And then I was washing with myself, and my teachers on those days were so sympathetic to me. Whenever I was meeting them, they were saying, Shomi, don't worry, we are looking for a job for you. So that's the way, because I was such a bad shape. So that's the way they looked at me in that way. But I still remember those teachers because they really was thinking about me. That's really very good. And then, but anyways, I spent little more than a year there, and then I took a break and aimed to do my PhD. And I did my PhD between 85 and 89. And Shishu allowed me for a 4-year leave. Can you believe it? That I got a leave from Dhaka Shishu Hospital. And then I came back, in fact, within 72 hours of submitting my thesis there. But unfortunately, my PhD did not help me to be a clinical microbiologist. Unfortunately, if you need to be a clinical microbiologist, I worked with the animal model to understand the enterotoxin of Campylobacter jejuni, how it works, this immunobiological relationship, or but nothing attracted Dhaka Shishu team members or the bosses, none of them, in fact. So as usual, I did not want to go anywhere else. I wanted to stay there because I got 4 years leave from there. So I shifted my gears. And however, when you are in the hospital, I really do not know Morshed Rubayat. You all know about this, or Niaz. You know about this. The hospital is a complex dynamics because all the hospitals, our management are really complex. It has got administrative group, it has got clinicians, nurses, laboratory personnel, other staff, and everybody think that they are the most important person. Nurse will be always thinking that hospital cannot run without me. So that's the complexity thing. So how you can manage it. So that's important, in fact. So and how you can really manage those complexities. So for example, you have policymakers, administration, research lab personnel, pediatricians, and clinicians. All of them are there. So if lab person is going to the policymakers, they will not really talk with you, honestly. So you will be getting refused with that. But better if you go and talk to the clinician and be with them, be friend with them, and together go to them. Go to the policymakers, that will help. So that's the way you can really do where there is no system, there is no way that, there is no even designation that clinical microbiologist if you are not a doctor. So it's very, very difficult, in fact. So, but these are the strategies, and that's the way from a broken table and a stool, how I can move forward. So these are the story, in fact, I'm talking to you. Okay. So when I really came back from PhD, I thought I have to do something, in fact. At least I did some research in my PhD. So, and the complexity is, as any other hospital, and Shishu not an exception, as I mentioned before. So international experts, I saw that any international expert, if they say a very big laboratory, a very big hospital with large number of patients, they're all interested to go there and work there. And they definitely want to work there. That's not a problem. They conduct the studies, they definitely collect the specimens, and they write the manuscript with this. However, there is no report is going to the patient. There is none of the hospital members are really an author of that. So all those are really is not really the rule, cannot be the rule. So this is called parachute epidemiology. That's the picture I was showing. You just go, take it, and go home, and then write it down and publish it. Sometimes you may be very kind to acknowledge them. So the collaboration. Every time they will come say, okay, let's collaborate. That collaboration is not really true collaboration. That's not the collaboration. If you really want to have the collaboration, you need this. That's the way you need to do it. And that's the way, in fact, you can really work when someone is coming to you from maybe abroad or maybe at home. There are a lot of international people, even in Bangladesh. They will come and they'll take it and they'll go back. So that's not really the right thing. So how things started rolling. So it's the communicating the results. I mean, all the clinicians, they are the boss. They will hardly talk to the microbiologist, honestly. Because your microbiologist, you are not the boss in that department. You are maybe third or fourth tier. There are a lot of people are there who are just will be signing on the piece of paper, not you. So that's the way it goes. And then when is it positive? So you communicate the result directly to the clinician. Be their friend or be the very small guy there. Just wait. Time will come. And then the volunteer for additional diagnostic work, something maybe they have not asked for, but that is possibly relevant to the result that you are doing. So you send it them. So they will be really coming back to you, and then they will be working with you again. So what is the base need? For example, we started doing some indigenous things because there's no resources, nothing. I was washing the glass plate and doing it again, and then it was so difficult to get it, in fact. So, and the rapid antibacterials we also tried, and also influenced the clinical colleagues, in fact. Few examples. What we did not have a blood culture system, very good blood culture system. It is taking 7 days, sometimes even 8 days to get it. So these are the things in 1980s. So lysis centrifugation method, then you really take the blood and then you put it directly on the plate because you have all polyethylene sulfonate, everything. And once it is done, and on the next day, within 24 hours, you'll be seeing the bacteria has been grown, Salmonella typhi, Klebsiella, E. coli, Pneumococcus, everything, because you have lysed the blood. You don't need to make a chocolate agar even, because you have lysed the blood, you will get everything there. And based on that, it is not only short turnaround time, it's also quantitative. You know the magnitude of bacteremia of that particular patient. So, and also the turnaround time. You come to the hospital in the morning, and first thing you do, take out the plate and make the lawn and do put for the susceptibility. And on those days, there's no automation system. So, and then you'll see within 18 hours, or maybe maximum 30 hours, you'll get the susceptibility. I mean, all together, this blood culture method, these two, you are given the report within 48 hours, both the things are done. So even sometimes before. So that's the way you are convincing your colleagues. And we really try to compare this with the CLSI guideline, that whether it is that 24 hours incubation and then this 18 hours incubation remaining same or not, that's also very same. One more interesting thing, whenever you are doing microbiology or clinical microbiology or whatever, or you're a technician, no matter. So you have to play with this. Everything is fun. Everything is fun. Sometimes I say we get so many Nobel Prize because we get something so interesting. And when you get so many interesting things, then I feel like that I have got an award. For example, most of the specimens are coming with prior antibiotic. When you have prior antibiotic, what we do, we put that strip on the middle, just wet, dry it, and then streak it across this. Once you streak it, then your antibiotic is remaining in the middle, and at the terminal, you'll be getting minimum antibiotic because you just streak it from that place. And then these are the places where minimum antibiotic. Look at this, what happens. You look at where the bacteria are, where the colonies are. These are the Haemophilus influenzae, and these are the Pneumococcus. They have grown just at the places where antibiotic concentration is minimum. I remember the CDC team came to my came to my lab, and they took the photograph of the blood agar plate to show that to their place in CDC Atlanta, that, okay, look at this. This is another way of doing it. So, but these are all very simple things. And I was impatient to do this, that what else I can do. So I can tell you that limited resources. In Bangladesh, you always call it limited resources. And limited resources and that improper and inadequate use. And then you don't generate any evidence. So that means it's a vicious cycle, but that's not true, in fact. Because every year you go to the end of the year, you'll see that you are not really could not spend all the money. So what we did, in fact, in our lab, that we optimally use it, and we really generated a lot of evidence, and then the optimum resources, and it turned to a vicious cycle. So that's the way we moved forward, in fact. So then we started working with pneumococcus, pneumonia, meningitis, and typhoid, and we worked a lot, huge amount of work we did for pneumococcus, and then we did the advocacy also just to make sure that we can convince the Gavi and other group to get the funding for the vaccine, and we got the vaccine introduced in 2009, Haemophilus influenzae type B, 2015 in pneumococcus, and then we got the vaccine, and then both the country is now using both the vaccine. The largest one, I mean, just to let you know, even with the clinical microbiology in a small microbiology lab, you can go to that level, in fact, from where you can do research, you can get publication, you can get funding. I'll be showing you all the funding also. Everything is possible. Only thing you have to have, dedicate that. For example, we started the work, we did the largest project in the world for the neonatal study. The Bangladesh, India, and Pakistan all together. We did this study, and the study was led by the microbiologist, clinical microbiologist from Dhaka Shishu Hospital or Child Health Research Foundation together. And our collaborators, WHO, CDC, Johns Hopkins University, all together, University of Toronto. And then ultimately we got more than 100,000 pregnant women and about 70,000 newborns. And from them, we got the etiology from this. And you look at this, is most of the etiology are viruses, and among the virus, mainly RSV. So what a great data. So all those are created by a clinical microbiologist in a small lab. So we should not really neglect this subject. This is the most important subject, and it's fun, in fact. So what is going on in ongoing pandemic, and what is our role as a clinical microbiologist? I can tell you, I have about 12 microbiologists with me, 15 doctors, and altogether about 300 staff working with me. And working with the government and helping Dhaka Shishu and other hospitals. And look at this, even we have this kind of facilities. This is the dashboard. That dashboard is always like clock. It is whenever you really put internet on that, immediately it will be running to see that how many. So more than 30,000 specimens we processed for COVID-19 testing to detect SARS-CoV-2, and until now is more than 10,000 cases were positive. So that was done from our lab. As we are more interested in pediatrics, look at this. The pediatric cases are as about 11,000 cases of pediatric cases. So all these are coming from the dashboard. And very recently, we published the largest series of coronavirus among the newborns. It's 26 babies, in fact, now even more. So this graph is showing the birth time, when they were specimens are being collected, how many of them are died. So everything there from this. So that's just recently published. And also, we also did the sequencing. You'll be happy to know that this is the team really who is coming from a basic science, the whole team, but sequencing was done there, first sequencing. And then all those sequencing are done in Dhaka based on the excitement of our sequencing. And the colorful those are from our lab. So those are the interesting things we do. So the differences are, you have seen the vicious cycle, but this vicious cycle is not really, we are just making the clinicians happy. We are also bringing the resources. From 2011 to 2020, this team has got the funding, which is about 36, more than $36 million in last 10 years till this 2020. So that is in Bangladesh. That's not an international organization. That's not really any systematic way to tell you that you are a clinical microbiologist, but you love the clinical microbiology. That's the most important thing. I'll say I was a technician. I turned to be I turned to be I got I became microbiologist then I scientific officer, and then now I'm professor of head, not only microbiology, only the diagnostic division, which includes radiology, which includes clinical pathology, which includes ultrasonogram and all those. Of course, the microbiology. So that's the way it's going. Um, I'm a member of Bangladesh Pediatric Association, which is eligibility is you have to be a doctor and have to have a post graduation in medicine or pediatrics. So, and then I'm organizing member of the World Society of Pediatric Infectious Diseases, Technical Advisory Group 4 committees in WHO. So all those are just, I'm saying that this is one of the subject we should love. And it's depending how loving you are for this. I believe that is the most important thing. Um, and, and confidentially, I must tell you one thing. I was demoted when I was assistant professor. Someone came and said, oh, you are not a doctor. No, you cannot be there. So demoted me. But that's fine. I became assistant professor again. My position was professorship was being cancelled. So my position was not there. So I should go out of the hospital. But I remained there and I'm still there. And I'm holding the same position, possibly even better. So that should be confidential. You should not tell anyone that I was demoted. However, my team continued even when I was demoted. That was not a problem at all. So the clinical microbiologist, definitely all clinical microbiologists are brilliant. I can see that the presentations of the new, younger one, Rubaiyat and others. So they are all brilliant, of course, but I believe if you want to be a clinical microbiologist, you have to have your heart also involved with that. So I'll say very important to your brain. But if you really want to do the clinical microbiology, then you also need to connect with the heart so that you can really do everything possible, in fact. And it is something endless, endless. You have got all resources. I can tell you the biobank that I'm having.
Sir,
I
sir,
don't know.
my apologies, sir. There's the last minute you have.
Okay, so
Okay.
I don't know really that anyone will have that much of organized biobank. I mean, the Klebsiella pneumoniae is so important to have a vaccine now. We have it till 1999. We still have the biobanks because on those days the sequencing was not there, but we were thinking that sequencing will be coming at some point. So biobank is still there. So there are many other things. Okay, I'll say thank you so much. That is the equation. You have to be together. And if you are together, then you are done. Thank you so much. Thank you.
Thank you, sir. Yeah, it's really great and wonderful presentation. And I have some questions in my hand right now. So let's start with the first one. It's from Sumaya Sultana. It says, "Dear Dr. Shaha, if we want to be a clinical microbiologist, then we have to be a doctor in perspective of BD, as you mentioned in your presentation. So my question is, what kind of job microbiology student can get in BD, and what kind of experience we need?"
I think a lot of opportunities are there. I can tell you this. Because you can see that number of microbiologists are working in my lab. Some of them are working in the routine lab, some of them are working in the maybe some of them are working in sequencing, but they are moving from one to other, one section to other section based on their interest. But I think job opportunities are many. And always remember, the private sector is really booming. So you have to go there and you have to make sure. Look at biochemistry. Same thing. Look at biochemistry. Each and every laboratory in Bangladesh are being managed by the biochemistry department students. So it is very important. It is our responsibility to make sure, as Brad was saying, you have to know. For example, if you want to go to WHO, you have to know someone. But I can tell you, you don't need to know all the time, because sometimes you need, but at our place, no. And at most, I can give you one example. The COVID-19 time, we had only 5 PCR machines. Now we have about 100 PCR machines. All those extra PCR machines are being managed by the basic science microbiologists or biochemists. So they really could manage it. But only problem is that they could not express themselves, or they could really make the tie with the clinical colleagues or the government uh, doctors. So those are important things. I think all these are available. You just have to look for it.
Thank you, sir. She got another question, follow-up question with these things, and that's just give me a second. So, if are you still hiring fresh graduates or microbiologists? If it is, what will be the process or opportunity in CHRF?
Advertisement. We advertise, and when the people will be coming, will be, yeah, Child Health Research Foundation. Go to the website, chrabd.org. Please.
Okay, thank you very much. Thanks thanks audience for the question. So I have another question from Dr. Afzal Chaudhry. And for those who are working in Bangladesh, any advice for them on how to establish equilibrium in collaboration, as you have shown shown in one of your slides? Nice hearing from your voice. Regards, Afzal Chaudhry.
Yeah, great, Afzal. It's nice to know that you are also here. Okay, I think we are collaborating with many groups, and possibly people are changing, and the collaboration is really very win-win situation, because we have resources. And I mean that we usually, what we do, we sit down, we then plan the study, and then we work together. So anyone can communicate with me. Absal, if you have anyone, or you yourself, if you really want to collaborate with us, we'll be very happy. I can tell you, we collaborate about 12 different groups, and we are mainly funded by Gates, also UK, British group, and also German. So, I mean, but also, but anyway, and the collaboration wise, we are very open, and we are always happy to collaborate with them. But we only do on the pediatric infectious diseases. That's possibly our limitation.
This is really a session today we had. We didn't have a data results slides, all personal experience, which is tremendously going to help all the audience, including those who are quite with gray hairs. I learned so much. Even in this country, United States, until very recently, all clinical microbiology was taught by medical doctors. But now they are all taught by microbiologists. It's changing in Bangladesh. I'm sure it will change faster. This is so important. What you want to do first, you have to like what you want to do. You have to love your work. So anyway, that was the comment I wanted to make. This is wonderful. Thank you very much, all the speakers.